presentation, I'd like to reinforce the knowledge of anatomic relationships by introducing several case-based congenital variations, both pathologic and physiologic, in abdominal pelvic anatomic structures. I'd like to start with the left side of the inferior vena cava. In this coronal CT, we can appreciate the heart, superior margin of the liver, and the structure connecting them, which would be the inferior vena cava. In addition, we can appreciate two large abdominal vessels that are spiraling in the abdominal cavity, one of which bifurcates. The bifurcating vessel is the abdominal aorta, and the other vessel that is approaching the liver is the inferior vena cava. If we move slightly anterior, we can better visualize the border between the two vessels, and again, the convergence of the inferior vena cava on the substance of the liver. In this case, the inferior vena cava is positioned to the left, to the patient's left, which is again not a typical anatomic structure. Normally, the abdominal aorta is positioned on the left-hand side. Similarly, on the axial view, we can visualize the abdominal aorta right here, the inferior vena cava on the posterior medial margin of the liver, and then as we ascend inferiorly, we can see the inferior vena cava widening and then eventual arching over the abdominal aorta, and assuming it's left position with respect to the abdominal aorta. The next case would be the duplicated inferior vena cava. In this coronal CT, again, we can appreciate a large vascular structure, which would be descending aorta. Remember that descending aorta turns into the abdominal aorta as it passes through the aortic hiatus, approximately at the level of the 12th thoracic vertebra, alongside with azygos vein and thoracic duct. If we follow it along anteriorly, so here's the abdominal aorta, this is more anterior view, we can start appreciating two other large vascular structures, one being to the right of the abdominal aorta, another one being on the left of the abdominal aorta and sort of again arching towards the liver. Moving more anteriorly, we can better visualize these two other large vessels which converge together and sort of join together in the liver. And then similar idea in the axial view. So here's the interface of the inferior vena cava into the liver. And then as we descend, we can clearly see the widening of the inferior vena cava and then eventual bifurcating into the left and right inferior vena cavae, as well as the abdominal aorta sandwiched in between. Next case would be bilateral duplex collecting system. In this condition, patient's ureteric bud, embryologic ureteric bud, bifurcates before interacting with metanephric mesenchyme, which sort of introduces these two poles, somewhat two renal pelvises with a Y-shaped ureter. This patient has it both in the left and right kidney. The left kidney is very clearly appreciated in this coronal CT, where we can visualize the Y-shaped ureter as it descends retroperitoneally anteriorly to the psoas major muscle and posterior to the gonadal vessels. So moving anteriorly, here, although not as clear, we can visualize this Y-shaped structure that again represents the bifid or Y-shaped ureter. On the right-hand side of this patient, the bifurcation follows more inferiorly than on the left-hand side. Similarly, in the axial view, we can visualize the ureter having two lumina instead of one single lumen, and being positioned, in this case, anteriorly to the renal vasculature, which again is an anatomic variation. Usually ureters are posterior to the abdominal vessels. And then moving even more inferiorly, closer to the interface of the ureter and the urinary bladder, like again I mentioned that the ureters are retroperitoneal structures and they approach the bladder from the superior posterior aspect. Here we can visualize two dots that will represent patient's right bifid ureter. The next case would be the horseshoe kidney. In this condition, the patient's inferior poles of the kidney fuse, and as they ascend from the inferior abdominal and pelvic cavities. So here we can see two poles. This is a posteriormost view, two poles of the horseshoe kidney, and as we move anteriorly, we'll be able to appreciate the fusion. There's a vessel that is positioned immediately superior to the inferior pole of the fused kidney. We'll better appreciate it on the sagittal section right here. If this is abdominal aorta, then the vessel that emerges from the abdominal aorta approximately at the level of the third lumbar vertebra would be the inferior mesenteric artery. And the inferior pole, fused pole of the horseshoe kidney is trapped under the inferior mesenteric artery, which prevents its physiologic ascent. The next case would be Mullerian agenesis, otherwise known as Menner-Rokitansky-Kuster-Hauser syndrome. In this condition, Mullerian ducts, otherwise known as paramesonephric ducts, fail to develop. As a result, the connection between ovaries and the patient's distal vagina is missing, which can be clearly appreciated in this T2 weighted MR of the female patients. This is a mid-sagittal section where we can see the pubic symphysis. We can appreciate the urinary bladder. And then the structure immediately posterior to it, although expecting uterus, we'll find a rectum and obviously the missing Mullerian structures in this image. Looking posterior anterior view, this is the posterior margin of the bladder again, and if we were to move posteriorly, we would expect a uterus being immediately adjacent to the bladder. And again, as we move posteriorly, we just see the very little margin, superior posterior margin of the bladder and no uterus. This hypointense structure represents rectum. More of the axial images of the same patients. As you recall, Mullerian ducts contribute the proximal 1/3 of the vagina. So patients with Menner-Rokitansky-Kuster-Hauser syndrome exhibit what's called a short, bluntly ending vagina. And in this case, we can follow the vaginal vault, the vaginal canal, superiorly, and we can see it bluntly ending. So here we can appreciate the rectum, and we can appreciate the patient's vagina. And then as we move anteriorly, the vaginal canal sort of disappears. And we see the urinary bladder starting. Thank you very much.